So today on the Doctor's Brew, we're going to be sitting down with Dr. Mohammad Jamal. Dr. Jamal is an associate professor of surgery at Kuwait University and a consultant metabolic, upper GI, and hepatobiliary surgeon. Everyone knows Dr. Mohammad Jamal. He's a household name here in Kuwait, and not just because of his many accomplishments as a physician and as a surgeon, but also because of his communication with the public. He's one of the people who's popularized communicating with the public on Instagram. And for me, he's someone that I do look up to. He's been a mentor of mine throughout my medical journey. And in today's episode, I'm super excited. It was a really awesome talk. We got into lots of different things. We got into exploring him as a person and his journey into medicine, how he saw it. And I think by understanding that journey, I got to understand that I wasn't alone in some of the things that I experienced or felt in deciding to go into medicine. It's not always the clear-cut, I always liked, anatomy, and that's why I went into medicine. It's a bit more complicated than that. We talked about dealing with difficult patients. We talked about the system in Kuwait, limitations, things that are improving. And we also talked about his specialty, talking a little bit about obesity, breaking down the stigma around obesity. So it was honestly a great talk. I hope you guys are going to enjoy this episode. And let's get started. That's the sound of the coffee pouring. Welcome to the Doctor's Brew. I'm your host, Dr. Abdulaziz Alkhayyat, and having coffee with us today is the legend himself, Dr. Mohammad Jamal. Welcome to the podcast.
Thank you for hosting me. I'm really excited to be in this podcast, and I have been following all your episodes since the start. I really love it.
And we really appreciate the support. Your support of us was critical in starting out, and I really appreciate it. I know that all our viewers must tune into you. I know that for a fact. He is one of the OG celebrity doctors of Kuwait. And before we dive into things right now, I just want to give a quick shout out to our coffee partners of this week, Earth Roastery. So today we're having a V60, and we also have matcha. So we're double caffeinated because we didn't have our caffeine during the day. So we need to stay double caffeinated.
Definitely.
And now before we get in, I want to ask, what do you think of the coffee?
I like it. I'm a big fan of the V60. Now, so far since Al-Futur, I had Qahwa Arabiya cold brew, but this is my V60. It's really smooth and nice. The taste is really good extraction. I love it.
If you approve of it, that means it's excellent. So that's your shout out, Earth Roastery. Just to remind you guys, they have an app and they have an online store. So we're gonna show a code right here at the bottom. Be sure to use it to get a discount, and be sure to visit their cafe. We can't stress enough how much we love them, and we love their sweets, everything. So go check them out. Yeah. All right, great. So let's dive right in. Dictor, the first thing I want to know is I want to hear your story about how you got into medicine.
Well, I never wanted to be a doctor, actually, until the final stages before the application for Al-Ba'that in the university. So I always loved reading. So they would go, what did you do before getting into medical school? I really liked reading poetry, humanities. I like chemistry as well. I loved physics. One thing I knew I did not like, which was mathematics. Okay, so knowing that medicine did not have mathematics, I don't have an exciting story about why I got into medicine. Really, I don't have anything special to tell. Even at my interview, I struggled. Right, so in your interview in the UK. You have to tell them why you are going to medicine. I couldn't find a good story to tell. I actually don't recall what thing I invented or what did I say to them. But so I don't have a good story. I just know that I did not like mathematics, and in medicine there was zero mathematics. My father told me I was very confused in where to go. I was between chemical engineering and medicine. And my father told me that, you know, I know you get bored easily, and medicine can be exciting because every day is a new day. My father was not a doctor, but when he put it in that way, and I started thinking about it, I thought, you know, if every day is a new day, and every day I'm having a new story in medicine, if it's really like that, then I want to go into that, especially that there is no mathematics in that field.
Right.
I guess that's why I went to medicine, and I don't have a good story, really. I wanted to try it out. I thought I will never succeed in the first year. I used to read a series of short stories or novels, and the main character loves somebody from Scotland, and he used to go to Scotland all the time. So at that time as well, in 1998, Braveheart, the movie, came out in Scotland, and you know, they offered going to Birmingham, Liverpool, or Scotland in terms of the UK, or Ireland. So the UK universities, if you wanted to study, you had a choice between Birmingham, Aberdeen, and Liverpool, or you go to the Republic of Ireland. So I thought, I'm going to go to the UK, to the Empire, right? And given the stories I used to read, and the castles, the lakes, I thought of going to Scotland. So I really didn't have much info going there. It's not like now whereby you can ask people, you can go on YouTube, you can go on Twitter, Instagram. You have so many resources now helping you in where to go. So essentially, I didn't have the greatest story to tell about going to medicine. And I thought, I'm going to go for 1 year. I even told my dad that I'm going to go for 1 year, and I think I'm coming back in a year, because my English wasn't that great as well.
That's something I wanted to actually ask you about, because when I went, my English was great. It was fine, right?
I know.
So for me, and the stuff that I was doing there, I couldn't conceptualize how difficult it was, and how difficult it is for my fellow Kuwaiti students who did not have.
No, don't compare me to your fellow Kuwaiti students.
How come?
Because probably your fellow Kuwaiti students went to private schools.
Some of them no.
No, so I went to Muqarrarat. It was the worst system ever for high school. So really, the English was so bad. Teaching English was so bad, and I cannot tell you how difficult it was. It was impossible.
That's what I mean.
I really thought I'm spending 1 year and coming back to that extent. It was impossible from the get-go. And to translate, I was lucky enough that at that time, you know, before, let's say a year before 1998 or 2 years before 1998, if you want to translate, you get there was a blue, like light blue, dark blue waves. The cover has that on the book, Oxford Dictionary. So you have to go to the Oxford Dictionary and translate word by word. But I was lucky that in 1998 something came out called, it was an electronic Oxford Dictionary. And you can buy it from Dualiya, كان بحولي. But you have to input every single word and then wait. It was so slow. So I used that for translation. I'll tell you something, just to tell you how difficult it was. So we had in our foundation year. Now you go to foundation year, it's much easier than medical school foundation year.
No comparison.
Especially in Aberdeen, it was so easy. The foundation year, not the medical school. And in the foundation year, we had chemistry, physics, mathematics, English, as well as cell biology. Was it cell or molecular biology? It was a cell or molecular biology, I don't recall. That was very difficult because it had, you need to do a lab every Friday. Now, I almost failed the first lab. So in every month there's an assignment in the lab based on the experiment that you are doing.
Right.
I recall that the first lab experiment, I almost failed in it because I didn't know how to answer it. So and I didn't understand anything from any of the lectures.
How could you?
Zero understanding.
Yeah, there's a
I did
major
not.
language
I
barrier.
could not take any notes. So I had no notes. I had.
You didn't do a language year, or was that not a thing at the time?
No, it wasn't a thing.
Oh,
so,
okay.
So, but I went for 3 months privately myself. I paid for some English classes before starting, but I was so. I felt so lonely at that time that I dropped out after one month. So I paid for 3 months and then I went home after the first month. I couldn't tolerate الغربة هناك.
صح.
It was in June, I recall, in
It's
a village.
Big hit.
Yeah, it was a village called Swanage. So I came back a month after the language classes. That's before the foundation year. So June 1998. I was supposed to stay 3 months and then go back to Kuwait, but I spent 1 month. زين هذا قبل البعثة. And when I came back, I told my father, this is hell. There is no way I'm going back. الغربة is extremely difficult.
And it was worse then.
Yes.
Yeah, because the communication with home is not like today.
صفر. Zero. So I came back and I applied to Kuwait University. Okay? Medical school. And at that time they used to do interviews. And the interview I thought did not go well. Okay? In Kuwait University.
I cannot imagine Dr. Mohammad Jamal
مالي لا يعني I think the interview didn't go well. I think maybe it did.
Okay.
That's my impression at that time. It was my first interview ever for anything. I thought I'm not gonna go into that. And then my father told me. So I always I'm easily intrigued, and you can easily challenged. Okay, because I think a challenge is an invitation for an unknown world. So I love getting into the unknown. I love discovering new stories. So I was intrigued in how, after spending 1 month there, it was so hard on me, right? How do people spend 7 years?
You mean as in fellow Kuwaitis, or how do people?
Fellow Kuwaitis.
Yeah.
How do they spend 7 years and study there?
Yeah.
And I couldn't do 1 month. That intrigued me.
Yeah.
Okay, what journey or what does it take for you to change from somebody who cannot tolerate 1 month abroad to somebody who can live there? And the fact that the interview I thought didn't go well, maybe it did, combined with that, and the feeling that I had a failure, right? So I came back after 1 month. That made me apply again for medicine abroad, and I thought, but I told my father I'm coming back in a month. So I wanted to try this out for myself.
Right.
And this is a recurrent theme in my journey.
Persistence.
Not persistence, taking challenges or trying to discover new stories, right? Getting intrigued by how could other people do it.
Yeah.
I couldn't understand anything. I remember there was a Danish student in the class, the cell biology, and I used to beg her just so that she can give me the note. She gave me the note 1 day, second day, and then she was bothered. I thought she wasn't happy giving me her notes to photocopy. So I stopped doing that, and it was horrible.
Yeah.
I thought, you know what? In my high school, I never studied. I would study the night of the exam.
Yeah.
Maybe so combined. I remember so vividly, sitting down with myself and thinking about this. I have a language barrier. Maybe my IQ is low, meaning that I should spend more time, right? So it's all about spending time.
But do you think that's the formula for everybody, or that worked for you? Because my fear sometimes is knowing the line between, okay, eventually I'm going to hit a diminishing return here. Like I'm studying for an exam. It's been 1 year. Every day I'm studying. Eventually, maybe this is the wall. What do you think?
Well, I think the more time you spend, no matter how difficult it is, the more time you spend, the more return you're going to get.
Okay.
Okay? So if somebody needs 3 hours, you'll need 10 hours.
Mm-hmm.
If you tell me I hit a wall although I was studying 12 hours, then you need 16 hours maybe.
Mm-hmm.
It's as simple as that to me at that time. I used to think about it. I used to think about it that way. So I thought I'm gonna study before the night of the exam. So I sat down, opened page 1 in chapter 1, and started translating the page.
Word for word.
Word for word. I remember the first time it took me 3 hours to translate 2 pages.
No.
I still couldn't understand what was going on in the lectures. And then a month or two later, I realized that the lectures are from chapter 7.
So you were in the wrong chapter.
I was in the wrong chapter. I thought it's like the high school. You open page 1. Wallah. I want to find that book because I love highlighting things. So every time I study, I highlight with different numbers just to tell myself how many times I studied the chapter. So I'm going to find that book one day to show that chapter 1 was only highlighted for the first 2 or 3 pages because we never went back to chapter 1 even later. So it was that difficult. And then I thought, you know what? Then if this is the case, I need to study the whole time.
24/7.
24/7. So I did that. And I got almost an A in my cell biology. And then I got full mark in my molecular biology 6 months later.
So it was off.
Huh?
Instantly. 6 months. I mean, for someone who didn't know the language.
Yeah. So, but I was spending so much time studying. I stopped sleeping the night of the experiment on Friday. And we had a TA. His name is Abdul Murad from Malaysia. He was a TA. He was in charge of our group at the lab. And then one day he came to us and said, you know what, you guys, I like you guys because we are from a similar background.
Right.
And I want to give you an advice. Okay. Can me and my friend Fawaz Lamtairi, he's a computer genius now. He left medical school. Okay, go ahead. He said, I advise you to leave science.
Okay.
Okay. We told him, okay, we'll leave science, but we're not studying science. We are studying medicine. He said, what? I thought I thought you guys are studying science, and I wanted you to go to business school or something. Now you're studying medicine? No way.
Yeah.
Then he didn't know this is a foundation as part of the medical school.
Yeah.
So he was extremely shocked that we are not actually science students. We are even going to go to medical school. He said, that you guys, it's a hopeless case for you guys. Wallah.
He doesn't sound like the best teaching us.
لا, I love him. I think he truly wanted to, يعني, لأنه we were so bad. I remember the first 2 months في الexperiment هذا, it was it was so bad. I cannot tell you. أنا بوصل how bad it was. بعدين, then when I got into medical school, started طبعا خلصنا foundation the first year, and then we went to medical school.
Yeah.
And in the medical school, I continued doing what I was doing. So I was studying the whole time.
Right.
The library, we had the Queen Mother Library. هي اللي افتتحت so the royal family of England, they would spend their summer in Aberdeen. هذا تاريخيا, historically.
Okay.
So they have 2 residences, right? They have Buckingham Palace.
Right.
Then they have Balmoral Palace, which is in Aberdeenshire. It's
Right.
just يعني على 15 minutes from where I lived.
Right.
In Aberdeen, driving. وحتى الحين that تشوف, if you watch The Crown, it's all, they give references to Balmoral Castle. The Queen Elizabeth died in Balmoral Castle.
Right.
ف كان في strong connection between the royal family and Aberdeen University. So Queen Mother Library, they close at 10 o'clock. I stay every day. So you get an announcement in the library 15 minutes before closure, another one 5 minutes before closure. I never left before the last one, the 5 minutes before closure announcement. Every day for 6 years.
6 years.
Yes, every day.
But
lectures would finish, let's say 4 or 3 o'clock. Lectures يخلصون عندنا كانوا, I think.
around 4 or 5.
Yeah, earlier even sometimes. So from the time lectures
Was
خلصوا.
this something you felt you needed to do, or was this because you wanted to excel at what you were doing?
I felt that it's either you excel or you fail. I couldn't come up with a formula in
The
between
middle, yeah.
for somebody who did what he did in the first 2 months.
Yeah.
صح, it was horribly bad.
Yeah.
The first 2 months.
Yeah.
It was scary bad. عرفت؟
And if
when
you push through that,
you know, it's a scary bad. So I never wanted to be in that situation. I tell you something. It's harder to be bad than harder to be, and it's easier to be good.
what do you mean?
يعني it's very hard to be a bad student.
How so?
يعني if you ask me now,
If you care about what you're doing.
if you ask me now, what was the hardest part of your life as a student? I will tell you the first 2 months.
Right.
صح?
Right. Yeah.
And then I tell you now that I spent 6 years studying every day.
Yeah.
To you this sounds hard, but it wasn't hard for me. Because feeling the pain of failure
Right.
and the pain of being of not understanding what's going on. Zain, this is more painful and harder than the pain of excellence, than the pain of hard work.
So what would you say?
So I think this is an important message.
What would you say?
Hard
to
work is
students who-
painful, but it's worse to endure the pain of being
Failing.
a bad student. صح ولا مو صح? Did you get that?
100%. And what would you say to students who that were like me? You know, I was doing well and fine, but what I struggled with at the start was really engaging with the material. The way that it was being taught, I wasn't vibing with too much. You know, but there was this fear in me of I'm not good enough.
I always had that feeling.
Yeah.
So I always had that feeling, and I used to tell myself, look, if being a doctor is about you'll be يعني as a doctor you are the شنو أقول لك الخط بين الحياة والموت.
Hey,
You're the line between
I
life
was
and
actually
death.
reflecting on this today. Yeah.
Okay.
We truly, yeah.
So I used to think to myself, if I am the line between life and death, بإذن الله سبحانه وتعالى طبعا. Then from today, I need to do what I'm doing extremely well, so that when I'm faced with a problem, with a patient, I can do well with that patient. I can offer him the best out there. فهذا something that was in the back of my mind as well. Okay, I don't want to do things halfway.
So you always had the image of tomorrow I'm going to be a doctor.
Yes.
And this is what drove you.
Yes, but also, I told you, so when I went to medical school the first year, I was doing that every day at 10 o'clock. And I got the prize in anatomy 3 months later, so it was in January. I got into, every year I used to get to the distinction vivas, getting distinction for 5 years.
Wow.
Because I was studying this much. And then I graduated with honor. I was at the top of my class in the middle. There was only one female above me, and she was already a PhD student, right? So we had 200 in our medical school. 40 of them were mature students. So 40 of them were pharmacists, dentists, PhD already. So she was a PhD in pharmacy. She was the one who got higher than me. I was the second, but the top male in the class and the top undergraduate student from 200.
Wow.
This story tells you from somebody in the first 2 months who was reading from chapter 1 when it was about chapter 7 to reach that, then it showed me that anybody can do anything.
And I hope people listening are getting
Anybody,
inspired by
I
this.
really, and وهذا شيء وايد مهم لأن it made me really believe that anybody can do anything, and I can do anything if I spend the time and focus. It's only about the time. And if you think about it, you own nothing in this life except your body and your time.
Yeah.
If I strip you of everything that you own, I cannot strip you of your body except if you die. And I cannot strip you from your time unless you die. Right?
Right.
So that's the only thing we own. It's the most valuable assets.
And so you
And
dedicate
since
your
you cannot
time.
control your body very well, you can control your time very
Yeah.
well. عرفت? Nowadays I'm, مع phones, social media, and all that, it takes a lot of your time. But if you think about it carefully, it's not, you are using it in your daily life. It's not that it's taking your time.
Yeah.
عرفت? فyeah, that's how I studied and I overcame the language barrier. If you look at the yearbook, so even in the yearbook, they wrote that Mohammed, there was a paragraph in the yearbook. So the students will write something about you in your yearbook. Is that what you do in Manchester?
We didn't have a yearbook.
No, we had a yearbook, so a graduation book.
I think our class was too big.
No, we had a graduation book, and everybody would put his picture, and somebody would write a paragraph.
That's beautiful. Manchester, come on, step up your game.
فاكتبوا one of the paragraphs, he was silent for 4 years. And once he mastered the language, he never shut up. Okay? For 4 years, they thought I maybe, and when I started talking to them, so for 4 years I couldn't talk, English wasn't easy for me even to communicate. So for 3 or 4 years, I didn't talk much. They thought they would see me in the library, studying all the time, not talking much. They thought this is the nerd. But then, when I started speaking English and they knew my true self, they were oh, is he okay? They thought that I'm undergoing a transformation or something.
Yeah.
And then I even went into the medical school. I nominated myself for the MidSoc. You have MidSoc in?
Yeah, we do. No.
Yeah, so I was the only foreigner to win in the MidSoc election.
Oh.
Yeah.
You weren't silent in the election.
No.
Okay.
It was the year before graduation.
So on the note of language barriers, I want to flip something to a question. Of course, you didn't go through this, but what about the doctors right now, the trainees who are coming from abroad, who are having trouble acclimatizing to now speaking Arabic? Because I'll be honest about this. One thing I've heard from people, like friends of mine have said this. They feel more nervous making mistakes in Arabic than in English. And they think that this is maybe a cultural thing. Whether you agree, disagree, I don't know. But I've heard this complaint from people, and people get nervous. I myself, I've gotten very nervous sometimes speaking to patients, words that I've gone into patient rooms before, and my mouth opens and nothing comes out because I'm nervous. I know the words, I know what I'm about to say, but because I've been so used to being abroad. So what would you say to us trainees, us juniors who are having that language shift issue?
So I don't think it's a language issue. It's simplifying the medical terms to people.
Okay.
That's the issue.
Right.
And it's very hard, and we have gone through this. كلنا we always struggled with that. لأن the public here will take your word word by word. So you need to be very careful in your language.
Absolutely.
Especially when they hear conflicting messages. So if you say something, your assistant registrar will say something else, the registrar will say something, and then the on-call will say another thing. The public here really don't like that. So any change in the narrative to them is a big change. It's الدكاترة ما يعرفون شنو فيني. Okay?
Right.
And they will call their friend and they will tell him, doctors here, they don't know what's going on with me. Can you please توصي علي? عرفت? So it always happens, but the issue is إن لازم يكون في, there must be a unified narrative to the patient. So when you round, the whole team needs to know what to tell the patient when they ask a question.
Right.
Abroad, we used to have family meetings. So I think family meetings is underutilized sometimes here. So it's good to have family meetings. لأن هني you have large families, and the sister will ask you, then the cousin will come one day and ask somebody else, and then they will discuss among themselves, and they will tell different narratives of the diagnosis or the story, and that will create confusion. So it's about having one narrative and having one source of communication, having family meetings. That will make things much easier in terms of communication.
Right.
So I think the communication issue is not a language barrier as much as a unified narrative that should be delivered to the patient.
And what do you think is the best way for us on the practical level, on the day-to-day, to confront our anxieties with speaking, and in actually communicating?
I think as a trainee, you shouldn't be delivering news to the family unless you know exactly what's going on and you know what, for example, if your consultant went in the morning and spoke to the family, you need to know what the consultant said.
Absolutely, yeah.
Okay, so it's also the team itself. The team needs to communicate very well. It's essential, and sometimes that's not happening.
And so whose responsibility is it? Is it the consultant or is it the juniors?
So the consultant, of course. So the consultant is not only responsible for the care. He's responsible for the communication between the team.
Right.
Alright?
Okay.
And it's your responsibility as well to communicate with the consultant and the others to know what's going on with the patients.
Well, I mean, sometimes the problem that I'll tell you, like بالخفارات, يعني one issue that we've often faced is that it'll be 2 a.m. and the patient's family is all there because they decided, of course, they're not going to come during normal visiting hours.
And they will call you to ask you what's going on.
Yeah, and it's
and
not
then
even
you tell
your
them,
unit.
I'm the on-call.
Yes.
And they will be very upset.
Oh, yeah.
And I think that's what you are doing through this podcast. And the families need to know how the system is working, that the on-call is responsible for the emergencies. When I was on call in the Glasgow Royal Infirmary as a trainee, I had 400 patients.
Yeah.
If those 400 patients, each one of them called me to deliver news to them, I will stop working. Khalas. People will die.
Impossible.
So they need to know that the on-call is different, and we need to spread the culture of asking for family meetings. So I tell my patients, look, especially when you have an acute issue, I would tell the patient, look, we can schedule a family meeting over the phone, or we can create a WhatsApp group, or we can all come together, bring all the family tomorrow at 10 o'clock, and I'll speak to every single one of you at once.
Right.
So that's what I do when I have a complex patient.
Well, I wanted to also ask you on the note of communication, you are very good at delivering bad news. And I know this through personal experience with my dad. Do you mind sharing with us a little bit about communicating bad news to patients? Because
so you need to understand the cultural context.
Yeah.
So in Kuwait, the patients, I think not in Kuwait, but I think I was saying that on Instagram the other day. I was giving a lecture on Dante, the Divine Comedy,
right,
in the Italian Cultural Week. And so I was doing an extensive search in that because I was I was not talking about the Divine Comedy in general. I was talking about the similarities or I was talking about the similarities or the resources that the Islamic and Arabic resources that influence the Divine Comedy. And if you look at the Divine Comedy, so when Dante went to enter the Inferno, so it's about getting into the Inferno, the heavens and the purgatory,
right,
اللي هو البرزخ بالعربي. So when he enters the Inferno, it's written on the Inferno, on the door, here is where hope does not exist. Okay? And that is, I think, the worst torture you can give to anybody, to tell him that there is no hope.
Absolutely.
This is you got your patient into hell when you start by saying that there is no hope, or when you tell them that there is no hope. And this is something that we were not used to abroad.
What do you mean?
يعني patients abroad, I think their cultural context allow them or make them, it makes it easier for them to let go of hope. Some of the cultures. يعني.
I'd agree, yes.
عرفت?
I'd agree, definitely.
يعني they like you to be very direct and very precise.
Yeah.
I think that, but I think giving hope is extremely important. And the other thing that made me give hope is that I have came across some patients that they were miracles. يعني I have two patients who one I did a YouTube interview with, I thought it was a completely hopeless case. And I remember giving him hope, and I was saying to myself, maybe I was wrong in giving him hope. Haram, and I gave him hope.
Yeah.
And it turned out to be a miracle story.
Really?
Another patient as well, I talked about a perforated pancreatic cancer. I gave him a bit of hope, and we struggled in curing him. He's now 8 years out of his
Really?
cancer.
Pancreatic cancer?
Yeah, perforated, with bilateral pulmonary embolism and a big abscess. Okay? It's a long story, but I wrote it on Twitter.
Wow.
Yeah. Sometimes miracles can happen, Zain, and you need to know that if you realize that letting go of hope is a torture, and you realize that I should be always, who am I to take hope from people, right?
Yeah.
I'm not God to take hope from people.
Yeah.
صح?
Absolutely.
So we should always fight until the end, but we need to balance things out. And we need to be prepared. It's nice to live with hope, but hope is going to be bad if you become delusional.
Okay.
صح?
I see what you mean.
You
Like
know?
when it's maybe end of the line and they're
When it's
choosing
end
hope.
of life, and then you want very aggressive measures, because this is torture again, right? So it's a balance. It's a balance, and you need to be very, very careful in balancing that out.
And now,
عرفت؟ my delivery of bad news يعني depends on not taking hope away without exaggerating it.
and now what do you do, because you were very vital in treating my dad, who's also your uncle. What do you do when there's family involved? How, because that becomes messy and complicated.
Yeah.
Yeah.
Yeah, it's really difficult.
Should you even get involved with family?
With your own family?
Yeah.
Yeah, I try to stay away from my own family, and حتى with your dad I was getting to Dr. Mohammad Al-Nassar, who I say يعني مسي عليه بالخير, والدكتور أمين الأنصاري. So they used to deliver the messages that I don't want to deliver, عرفت?
Yeah. That's actually that's a very good point.
زين بس at some point لا I was asked directly, and I had to answer. يعني it's better to avoid treating family, of course.
You think so?
إيه طبعا. But when you as a doctor are confronted by a patient family, زين, then you need to be clear. Best again, وازن or try to balance between letting go of يعني preparing the patient for his end of life decisions, best not taking hope away. It's a difficult balance to attain.
Extremely, and I think what you said earlier about the culture, shifting the culture in Kuwait, about understanding the roles of the doctor, is also critical in delivering the bad news. Because if I've been in places before where I had to manage a patient and his family and the psychology of the news that they just delivered and whatever, and this shouldn't be on the on-call.
أبدا.
Never.
You should get yourself out of it.
In fact, I once...
As a trainee on call.
I was telling a friend of mine, I said that I think communication-wise, if we stuck to, not limited, the official rules, there are official hospital visiting times for family.
Yeah.
I feel, from my experience, that if we stuck to those rules, we would take away 70% of the communication problem that exists between
صح.
the doctors
صح.
and
True.
their families right now.
True.
But then, okay, in Kuwait, the state of Kuwait right now, how do you feel about communicating these messages to the public? Are we a hopeless case?
You need to communicate these messages. I think وزارة الصحة, the Ministry of Health should take that into consideration. And لأن بالنهاية, at the end of the day, the miscommunication that is happening is making the public lose trust in the medical establishment. That's why you really need to improve the communication. The doctors here are excellent. A lot of doctors are doing a great job.
The talent is amazing in this country.
But sometimes the communication is the issue, and the mass communication, the communication with the mass public by the Ministry of Health, can be an issue if it's that not if we don't focus on that.
Do you think that the public doesn't trust us?
I think they trust individuals.
What do you mean?
They trust individual doctors. They don't trust the whole medical establishment. And part of it is the treatment abroad. Part of it is the issue with the communication that we're referring to. part of it is them not understanding what the doctors are doing. And the other day I was in the clinic, Zain. I was having my hepatobiliary clinic في Jabr Hospital. And I was just waiting for a 70 years old who I did the Whipple procedure for in the corridor. And she's coming, يعني, I wanted to wait for her in the corridor, not in the room. Next to me there's the plastic surgery clinic. It's so busy, the plastic surgery clinic, right? Fortunately, the hepatobiliary clinic is not that busy, then it's all cancers. And there was a lady who was waiting for her turn to the plastic surgery clinic since for a long time, like 3 or 4 hours. So her turn came out. She walked in the corridor and she saw me standing as a consultant. And she was telling to her friend, look, I was waiting for 4 hours and this doctor is doing nothing. I was like, I didn't say anything.
Oh yeah.
You know, they think we are like, يعني شايف شلون انت تدش على كاشير كاشير الجمعية صح. You know, at the cashier in the جمعية, if the one cashier is busy, you go to the next cashier who's not busy. They think we function this way. Zain?
It's true.
It's not their fault. It's our fault that we are not communicating how we are functioning in the hospitals.
But by our fault, do you mean doctors or do you mean the system?
The system, the whole system.
Establishment, okay.
They need to let the public know what we are doing. That we have, as a surgeon, I have a day of clinic, I have a day of surgery. Maybe at the time of the day of my clinic, I have an important meeting or an important lecture to give. عرفت?
Yeah.
So they need, or I get called for an emergency surgery. So as a hepatobiliary surgeon, we are very few hepatobiliary surgeons in Kuwait. We can cover anywhere in Kuwait if there is a hepatobiliary emergency. So people don't understand that. And if they don't understand that, you cannot blame them.
Right.
عرفت؟ يعني الحين we are giving this in English حتى الناس ما راح يفهمون وايد. You should put Arabic subtitles.
No, inshallah, in the near future. That's definitely coming up. Great. So we're back from our quick break there. So we were talking a little bit about communication just now.
Yeah.
I want to move a little bit closer to home for you, closer to your specialty. I want to talk a little bit about surgery, different options for medical students after graduating, that kind of thing. So after you left, you finished med school, you told me that you weren't intending on surgery initially.
So initially in the medical school, again, I wasn't intending in doing surgery.
No.
I loved everything. I loved neurology, hematology, psychiatry, infectious disease for that matter.
Infectious disease?
That's
too much memorization for me.
I loved microbiology. And then I really enjoyed, I attended one cardiac surgery and I like that, seeing the heart beat in front of you, it's magical. My supervisor, so in our medical school from the first day they get you to a supervisor, Zain. So my supervisor was the president or the vice president of the Royal College of Surgeons of Edinburgh, Professor Youngson. Incredible man, demeanor, character, stamina, teaching, and he was a pediatric surgeon.
Okay.
That got me, I remember a year before the end, and my mother developed breast cancer, and my aunt, Allah yarhamha, as well developed breast cancer. I was in the second year of medical school, and I asked so many questions. Again, I got intrigued. So why did my mother have breast cancer surgery plus lymphadenectomy plus chemotherapy and radiotherapy, while my aunt had only a lumpectomy plus radiotherapy? She did not get chemotherapy. So these questions intrigued me. And another thing is, you know, when they teach you knot tying, that I was so, when the first time you tie a knot, it's so hard and difficult. And when you go to the surgery, they are doing a hernia surgery, and he tells you, oh, this is the vas deferens and this is the sac and I'm tying it, and you have no clue what's going on because this is so different from the anatomy books. So I was telling myself again, what's the journey that makes somebody like me who's finding it so hard to tie the first time he's tying a knot, and not understanding the first time watching a hernia surgery what's going on, to do it like that, like he's driving a car.
Yeah.
Like he's
Second nature.
Second nature. It's like he's driving a bicycle. How could people do this?
Yeah.
عرفت? I could comprehend how people do medicine and psychiatry. Of course, all of this is difficult. يعني.
Yeah. No.
Any specialty is difficult. But يعني you can imagine it. It's studying, experience كذا. But actually doing the surgery with your hand this way. عرفت?
Foreign.
Yeah. هذا it's something that really got me intrigued جدا wide. عرفت? Again, I got the prize in anatomy in the first year. So I always loved anatomy, loved microbiology. So microbiology, immunology, anatomy, they form the basic science of surgery. The impact that you get in your patient, it's instant.
Of course.
Sometimes the patient is dead. He comes to the emergency room dead, literally dead. There is no pulse in trauma, for example, and you get him out of that.
Right.
It's just incredible. It's amazing. So that's what got me interested in surgery. القدوة, a role model اللي هو the pediatric surgeon. الjourney, thinking of how challenging this can be. Questions that I wanted to get answered for my aunt. She developed liver metastasis, so why we cannot remove these liver metastases? Why there is no cure for it when it's from a breast cancer? So that's what got me interested in surgery. And I knew in my final year, it's not until the final year, that I knew that I'm going to go into surgery.
And do you think that there's personality types besides interest?
Yeah, in my first week of medical school, I remember meeting with the surgeon, and he told me, "You're not going to do anything but surgery." And I will challenge you.
So what are the personality
I'm going to
types?
be right. يعني شوف, you cannot generalize, but I think you can tell.
I'm not going to be a surgeon.
لا, you do have that character.
You think so?
Yeah. Anybody can be a surgeon. بس يعني people misunderstand surgeons. So sometimes they say, oh, they are firm, narcissistic, they think they are always right, they are arrogant. هذا typical.
This is for the trainees that are terrified of their surgery rotation and are going to Kim's requesting for the change right now.
Yeah. But the thing is, in the acute surgery, especially in the acute matter, mistakes cannot happen, because any mistake can deviate the patient. So you need to be firm, you need to be thorough, you need to know what you're doing. The decision making is essential. Sometimes it takes seconds for you to make a bad decision and kill the patient, especially in trauma surgery, when you have a major adverse intraoperative event. So even intraoperatively, it's like, let's say you're in a plane as a pilot, and the plane is falling. It's instant. You need to make it. Sometimes you are faced with similar issues during surgery. You need to make instant decision. Any delay can kill your patient. So you need to know what you are doing, and you need to trust your gut feeling, right?
Yeah.
You need to develop these reflexes.
You know, I've always wondered, what is failure like for a surgeon? Because I can imagine failure for, let's say, internal medicine. I gave the wrong antibiotic, I'm going to switch it. But in those brief seconds, those moments, and I'm certain they've happened in every surgeon's life, because nobody's perfect, you know? So, but what does failure in surgery look like? What should a future surgeon expect, mistakes they're going to make on the job, and how to rectify that?
So it's not about mistakes. It's whenever you have an adverse outcome, you will always blame yourself, and because there is a direct link between your action and what happens to the patient. So the surgeons will not blame anything but themselves. They will not say, "Oh, the suture wasn't good." So in other specialties, they'll say, "Oh, the antibiotics. The patient did not respond to antibiotics."
Right.
So it's the antibiotics' fault.
Yeah.
صح?
Yeah.
The patient did not respond to this.
It was not the
medication
clinical decision. Yeah.
You know, we cannot say that. There is a book by Charles Bosque. I think he's a PhD in UPenn. He's a social medicine specialist, PhD in UPenn. When he was a PhD student, he did his PhD as an ethnographic study, shadowing a surgical team for 4 years. And in that book, it's called Forgive and Remember. He talks about all that the surgeons are under tremendous pressure because they always blame themselves when it's not their fault. عرفت? So no matter what happens to the patient in terms of adverse outcome, you'll always think of how I can change that. I recently listened to an interview with the greatest surgeon of the 20th century. His name, he's the inventor of liver transplant surgery, Thomas Tarzil. And the first 150 transplants that he did, liver transplants, the survival, guess how much was the survival in the first year?
Let's say,
so
brand new is
150 patients, yeah.
Let's say 30%?
10%.
Oh no.
What was the survival for 2 years?
If it's 10%, 5.
0%.
Okay.
Nobody survived more than 2 years for the first 150 cases. And I always thought that, you know, maybe he's somebody who was careless. Not careless, he's very careful. He's somebody who doesn't spend time blaming himself. And then I listened for another interview. I listened to another interview with him. They asked him. He stopped operating in 1990 because he had a heart attack.
Right.
So they asked him, "Did you miss surgery?" Because if you ask any surgeon when they stop operating, "Did you miss surgery?" They'll say, "Oh, of course I did." He said, "No, I didn't miss it."
Why?
For somebody who did so many complex surgeries.
Yeah.
And they asked him why. He said, because every day I lost a patient, it was like a doomsday for me. And it was nice to not have this feeling again.
Right.
And I was emotionally wrecked at the end of all that. I remember every single patient as part of my family. I have a graveyard, and that you will hear that from many surgeons, that they have a graveyard that they will always visit to remember their patients.
Do you have that?
يعني especially in the complex surgeries. يعني I'm fortunate to do straightforward surgeries in the field of obesity surgery. I do straightforward surgeries. But in my other specialties, in my other specialty in hepatobiliary surgery and liver transplant, we do have, it's very major and high risk, sometimes high risk surgery. So it's very emotionally, it's very consuming and very difficult. It's literally like, يعني, there is a study showing that 30% of patients experience post-traumatic stress disorder, same way as the soldiers experience during
after surgeries.
After surgery, especially when they have an adverse event. So emotionally, it's very challenging, and it leads to major psychiatric issues, burnout, and you are an expert in that. عرفت يعني it's not easy. It's not easy.
I mean, this is. I think the personality element when it comes to choosing a specialty is very important. And taking things like this into consideration, like what is quote unquote the graveyard that I'm gonna have, you know, because definitely every specialty has a different list of patients that are, like, for example, in psychiatry, I'm on my psychiatry elective. What I'm noticing is you're not going to have maybe patients who passed away, but your patients are maybe patients who just are non-adherent or don't like you, and they're stuck in psychosis. Or they're cursing at you.
Well, that's very, very challenging as well.
Of course.
The issue is you will have adverse events. It's not that you'll have mistakes. Mistakes are not allowed, but adverse events, they can happen because you don't control everything.
Of course.
Now with COVID, you get somebody who gets COVID, they get Neshle. Somebody else gets COVID and they get into the ICU. Somebody gets COVID and he doesn't discover it unless he's traveling to do a PCR, صح? The response of the immune system is in charge of everything. And that's what's happening in surgery. It's the response of the immune system. It's what determines how healing is happening.
Right.
So we cannot control everything. And that's something that is very essential to be understood in the future among the surgical community and among the public.
I remember, when I was in my orthopedic rotation, on the topic of immune response, I still remember how it was a bit of a light bulb moment. I always read in textbooks patients shouldn't smoke after orthopedic surgeries or after surgeries, delays, healing, etc., etc. But it was only when my orthopedic surgeon sat down with his patient and he looks at him in the eye and he just said, listen, I'm not doing anything for you until you stop smoking, because there's going to be no use. So you are really in a battle with the immune system.
Yeah. It's all about the immune system in surgery. That's what I believe. You have to optimize the immune system before the surgery, and that's by losing weight, exercising, eating well, stop smoking. That's how you optimize your immune system.
All things that are very difficult in Kuwait.
Sometimes, yeah.
So your other specialty is focusing on
weight loss.
Weight loss.
Yeah, and it's very common in Kuwait. So the majority of the surgeries I do in Kuwait is related to weight loss, because we are one of the highest nations on earth to have obesity.
Why do you think that is?
It's genetics and epigenetics. Our genes are not made, in general, I mean, our genes are not made for this life in which we have so calorie condensed food, you know. In the past, for you to eat this much calories in one setting as a hunter-gatherer. So 95% of the human history of our genes was during the time of hunter-gatherers. The hunter-gatherers will run marathons to eat, you know, what can you eat? If you would run a marathon just to eat فخذ أرنب. How do you say فخذ أرنب in English?
A rabbit thigh.
A rabbit thigh. عرفت? To eat 700 calories at that time was impossible.
Yeah.
Can you think of, at the time of being a hunter-gatherer?
We're still stuck with this?
Yes. Yes, because 95% of our genes were developed at that time.
When you frame it that way, it makes more sense.
Hey, عرفت? Tell me, as a hunter-gatherer, how could you eat 700 calories in one setting? Impossible.
Impossible. With a bow and arrow, what are you doing?
Now, ice cream هالكبر 700 calories مري عرفت؟ sneakers مع وجبة هارديز هالصغر you get 700
The system is now against you.
It's against you, إنزين. It's against you, and then at that time يمكن by 7 o'clock in the morning you get 12,000 steps. Nowadays I'm measuring my steps with this.
You struggle.
You know, if I don't exercise, it's the average is 4,000, 5,000 steps, which is nothing. So you do your workout in the past just to eat. Right? Right? So, and our genes are not made for that.
And so now when you see an obese patient in the clinic, what is their journey? What are the options? Where do they go?
So morbid obesity, now we practice evidence-based medicine, right? So anything that we should recommend to our patients is based on studies. And the highest quality of studies is randomized control study or a meta-analysis of randomized control trials. There is no single randomized control study with more than a year of follow-up showing that if you are morbidly obese, you can lose weight and keep it off with diet and exercise alone.
Okay. So it's a necessity.
So telling a morbidly obese to lose weight with diet and exercise, that's not supported by evidence. It's against evidence. It's like telling a psychiatric patient, go...
be happy.
Be happy.
Just flip the switch.
خلي عندك إرادة. Strong will.
It's an insult, really.
It's an insult. صح? So why you accept that with the morbidly obese? Are getting bullied every day, everywhere.
It's highly related to psychiatric comorbidities, depression, anxiety, all of it.
I have patients, you know, when they gain, so some people when they gain 10 kilos and they look different, they stop going out of their home. فما بالك في الموrbidly obese, somebody, يعني, she got married, her height was 1 meter and 60 centimeter, and she was 55 kilos. 10 years later, she's now 90 kilos, and she cannot keep it off. And she goes out, and maybe some people didn't see her for 10 years, and they see her and they don't recognize her. People don't recognize her. And some people can have that in 2 or 3 years rather than 10 years. It's a huge impact.
I see people changing their behavior just over 5 kilos.
There are studies showing that the morbidly obese don't go to clinics where they take their weight. Then it's a traumatic experience for them getting into the scale.
But how much of obesity do you think is actually just a willpower thing?
There's no willpower. in medicine. Tell me one disease that when a patient comes to you and asks you for a cure or for help, and you tell him go and get your willpower to help you. الحين, morbid obesity is related to 240 diseases. Okay? If your BMI is 35 or 40 at the age of 25, you lost 15 years of your life from the get-go. And you are going to lose these years and live the rest of your life with an impaired quality of life. عرفت? This is proven in numerous studies. It's the number one risk factor for cancer. It's not smoking, it's obesity, morbid obesity. It's the major risk factor for cardiac diseases. يعني the top two killers, cardiac diseases and cancer, is caused by morbid obesity. It causes type 2 diabetes, hypertension, hypercholesterolemia, stroke, cardiac events, right?
Pretty much everything.
زين مفاصل, علام مفاصل, joints. So when we have somebody who's diabetic, we don't tell him to use willpower. If he eats 1,000 calories per day, he will not need medications.
No.
But we call them stupid if they don't go and see a doctor. صح?
True.
So why we do that to morbid obesity, which is the cause of type 2 diabetes? It's a philosophy. عرفت? Medicine is about defining. What's the philosophy of medicine? Medicine is about defining what's disease, what is a disease, okay, and what is health. And what to use as an intervention to move somebody from being ill to healthy. صح? زين? So we are the ones who define what a disease is. We did not define obesity as a disease because we did not understand it until recently, over the last 20 or 30 years. Right? Now we have so many options. We have medicine, we have endoscopic treatment, we have surgical treatment. We don't need to go to surgery right away.
Yeah.
So we have so many interventions that we can combine
Many different
and
options.
use, but we need to understand that diet and exercise is not going to get you anywhere if you are morbidly obese. It's an adjunct to others. So even if you have in psychiatry, you will always use diet and exercise with sleep, diet, exercise,
If a patient is not
strong
sleeping,
will, along with medication. But if you don't use the medication, all this is not going to help.
absolutely.
صح? So it's the same concept.
But how do
The
you,
issue is as well, we have so many people who are not specialized in obesity, who are taking over that field. Dietitians, with all due respect. Some dietitians are very good and they understand that, but some will they totally use the opposite message to deliver. We study in medicine so many disciplines just to make us understand what a disease is, what health is, and balance the risk and benefit of our treatment when we select the treatment. عرفت? They study one field and they start telling the patient what a disease is, what health is, and they suggest treatment. And this is wrong. The other day I was listening to a podcast. They asked a dietitian, what does he think of Saxenda for a patient? This is not his job to answer that.
absolutely not.
This is not his specialty, because he doesn't understand what a disease is, what health is, and what are the risks and benefits.
Just like how we're not dietitians, they're
Right?
doctors.
Right?
It's a two-way thing.
But as a morbidly obese as a morbid obesity specialist, metabolic specialist, I understand all these disciplines in order for myself to suggest the treatment. So all my research in the lab now is in metabolism, right? So we are at a higher level in our understanding of our understanding of disease and health, right? This is the essence of medicine, and all these disciplines take us to there. It's not that our field is better than their field, but it's our job and it's our field that allow us to suggest treatment, because we understand the line between medicine and between health and disease, and we understand what is the risk and benefit for everything that we suggest. Similarly, you can see some pharmacists telling patients not to use a certain drug. They shouldn't do that.
That's not their job.
They shouldn't do that. They can advise you as a doctor that, you know, maybe this dose is wrong, or this medicine will interact with this medicine. But you shouldn't tell the patient that, there's a side effect of this medicine in your kidney when your psychiatrist prescribe lithium.
Because the psychiatrist has weighed the
He weighed it out already.
Yeah.
He did that.
You're interfering with the management.
You're intervening with the management. Right?
But you know what I wonder is, what is the role of maybe mental health and psychiatry to get the patients to your clinic? Because the issue is not like...
So a lot of my psychiatrist friends, Dr. Mohammad Swaydan, وجلة تحية, Khalid Saleh, Dr. Maryam Al-Awadi, Dr. Samal Al-Khwari, work closely with them. They refer to me their patients, and we manage them collaboratively after surgery.
This is excellent.
Because I remember one patient was on 6 different drugs, psychiatric drugs, and we got him to 1 only after surgery.
Really?
Yeah.
That profound of an impact, the obesity
it's
on
huge,
his mental...
Huge. There's a strong link between your mental health and your weight. There are some studies showing that, because who's in charge of your weight? It's the brain with the gut, and they communicate with each other by hormones. So they don't talk in Arabic or English. They send hormones and إشارات عصبية, right?
صح.
There are studies showing that when you are morbidly obese, so morbid obesity is a disease about fat storage, essentially. Your body thinks that it needs 40 or 50 kilos of fat, to prepare you for the next starvation, because that's what was happening in the hunter-gatherer period. You have spring, abundance of food, you store, you get fat, right? So that when winter happens or summer happens, you can burn that fat to survive. Your body thinks when you eat 700 calories at once or 1,500 calories at once, the body thinks, we are preparing for a major attack. عرفت?
Yeah.
Guys, let's sit down. Let's change our set point. There is a نفس مثبت السرعة, the cruise control in the car. There is a cruise control for your weight, a set point. Let's set the weight at 150 now, and let's conserve the food that we are eating instead of burning it, and let's make it into fat right away. Because this guy, he knows what he's doing, and he's doing that because he's preparing for the starvation. When you diet, the body meets again and says, we got into the starvation, guys.
Yeah.
This is the starvation we are preparing for. Let's not burn the food. Let's conserve this fat, because you don't know how bad it's gonna get. عرفت?
Yeah.
And with time, and because you kept your fat stores for so long, 3 or 4 years, then the body will maintain those fat stores. Not like in the past. In the past, you get fat for 3 or 4 months, then you burn them 4 or 3 months later. عرفت؟ وهذا اللي تشوفه مع الممثلين. أحيانا an actor needs to be to take a role as like the whale.
Brandon Fraser لما مثل.
So he needs to be fat. He eats a lot of pizzas for 2 or 3 months, and then he burns them.
Yeah.
مع الأسف, unfortunately, some of the fitness coaches, they do that to show the morbidly obese that they are lazy. So they eat so much and say, look, I'm fat now, I'm going to burn it in the next 3 months. And he burns it in the next 3 months because he doesn't have the set point.
Right.
There's no major metabolic changes in his body. Unlike the morbidly obese. عرفت? That's what's happening in morbid obesity. It's a disease of fat storage. There are studies showing that there are hormones and lipid metabolites that directly affect the brain and cause depression in the morbidly obese. A direct causation by some of those metabolites going into the brain.
That's amazing. So, this just shows the value of the multidisciplinary team. Yeah. Because if you're going to have your depressed patient who's going to continue being morbidly obese, you can keep throwing SSRIs at them all you want.
Yeah. And so we work closely with the nutritionists, dietitians, pharmacists, medical specialists, psychologists in the treatment of morbid obesity. The multidisciplinary approach is extremely important.
And what are the options that you give to patients in terms of
So if they are morbid obese, I prefer to go to surgery. If they are not willing to go to surgery, we can do a combination therapy. So the first stage, we put a balloon, either a swallowable gastric balloon or a 1-year balloon. or we can do an endoscopic treatment which will suture the stomach. It's called endoscopic sleeve gastroplasty.
Okay.
That will be the first stage. The second stage will be combining it with one of the new medications for weight loss. Medications in their own, they can work, but I think once you stop them, you regain all the weight back. So it's better to use them for maintenance, or to use them to amend the weight loss with the combination therapy.
And now the meds are only for morbidly obese patients, or also
I'm
just...
talking about a morbid obese patient. But like in any disease, you need to intervene early. Okay, because the disease is not going to get better and so on. It will only progress and gets worse, right?
Right.
So if you have somebody with class 1 obesity, like the BMI is 30, right? I will not offer surgery, but I can offer the combination therapy that maintains the anatomy instead of changing it by doing endoscopic treatment combined with the medical treatment to avoid getting into the morbidly obese.
Right. Well, Dr. Thank you so much for coming on the podcast.
Thank you for having me.
It's been
I enjoyed
amazing. I've learned a lot. I've been inspired. And now I know that if God forbid I get obese, I'm going to be knocking on your door. So this has been Dr. Mohammad Jamal. That's the last sip of coffee for the day. I hope you all enjoyed this episode. I know I did. Please be sure to like, comment, and subscribe. And stay tuned for more amazing content. And please follow Dr. Mohammad's Instagram pages and social media for all his latest updates.
وانت اكونتك تو حاطه بالانستغرام. Your personal account.
I'm not even used to
You forgot
promoting my
your
own account.
dr.a.a.
dr.a.alkhayyat. Both of these tags are going to be put here on the screen magically. So be sure to follow these accounts, follow Dr. Mohammed, follow mine if you want to know more about the Doctor's Brew, about my life, about my practice as a young doctor. Thank you again.
Thank you for having me again.
Hope you all enjoyed this episode of the Doctor's Brew. New episodes to listen to with a cup of coffee coming your way every Sunday on YouTube and Spotify. And be sure to follow us on Instagram for all the latest updates. See you next time.